So, in pediatric imaging, urethral anomalies should be known, and today we will talk about urethral anomalies and their imaging. Urethra, it is best demonstrated by oblique lateral projection of micturating cystourethrogram or retrograde urethrogram, and it is the best view which shows the bladder neck and posterior urethra, and this is very important to rule out anatomical cause of bladder outlet obstruction. Bladder outlet obstruction may be due to anatomical cause or due to functional cause such as neurogenic, and anatomical cause of bladder outlet obstruction has a lots of causes, but the most number one and most important cause is the posterior urethral valve. And ureterocele, if it prolapses into the posterior urethra, it may cause obstruction. Urethral dysplasia, dysplastic urethra may cause obstruction anatomically. Anterior valve, diaphragm, or syringocele may cause bladder outlet obstruction. Mutual stenosis, another cause. Paraurethral cyst, urethral diverticula, or duplication may cause anatomically bladder outlet obstruction. Trauma can cause infective cause may lead to obstruction. Severe hypospadiasis is also a cause. Pelvic tumors or urethral polyps can cause obstruction, as can bladder mass such as hemangioma or neurofibroma. This can be demonstrated by ultrasound, especially perimicturational ultrasound can show polyps. But for the assessment and the staging purpose of a pelvic mass, MRI is the imaging of choice. So, how a congenital urethral obstruction is presented? Congenital urethral obstruction, it creates a spectrum of disease with the timing and severity determines the presenting symptom of the children. If the boy has high grade obstruction, then the boy will present as neonate with urosepsis, renal insufficiency, and pulmonary hypoplasia with severe respiratory distress. And the boy may be shown by antenatal ultrasound as urinary ascites, oligohydramnios, enlarged bladder, and renal dilatation. Less severe obstruction may lead to presentation in childhood with urinary tract infection. So let us talk about posterior urethral valve. Posterior urethral valve consists of abnormal folds of mucosa between the wall of the urethra and the verumontanum. So it is the abnormal fold of mucosa between the wall of urethra and verumontanum. There are three types. These range from type 1 is slit-like has a slit-like orifice, and type 3 has a pinpoint-like orifice. Type 1, this slit-like orifice between two folds at the verumontanum, and in type 3 has valve with eccentric pinpoint aperture causing the valve to balloon forward on micturition. On the micturating cystourethrogram, this may be shown as wind in the cell. With type 3, it is associated with renal dysplasia even without significant upper tract dilatation. So, how we will assess? Always we will assess for posterior urethral valve if a newborn boy present us with significant antenatal, if the newborn boy had an antenatal hydronephrosis grade 3 or more, and thick bladder wall ascites or oligohydramnios, then we will always assess the newborn boy if he has posterior urethral valve. And if we suspect posterior valve, then uh, we should go for suprapubic bladder drainage until valves are ablated with secondary obstruction at the vesico-ureteric junction. A nephrostomy may become necessary to ensure sufficient urinary drainage. So, how a posterior urethral valve can be imaged? Ultrasound may show hydroureteronephrosis, renal dysplasia, urinomas due to calyceal rupture secondary to increased pressure. So, hydroureteronephrosis, renal dysplasia, urinomas due to rupture secondary to increased pressure, and bladder wall thickening with a dilated posterior urethra and hypertrophied bladder neck. Baby should be well hydrated so that hydroureteronephrosis is not underestimated. And micturating cystourethrogram, it is essential but it is contraindicated in case of acute sepsis. Contrast medium may show bladder wall trabeculation, very large or small bladder with diverticula, and unilateral or bilateral vesico-urethral reflux associated with poor renal function. The valve is visualized as an acute caliber transition on the oblique or lateral urethral projection at micturition. Follow-up, when we will do follow-up micturating cystourethrogram, it is useful after cystoscopic valve ablation, but cystoscopy is required as remnant valve leaflet may be missed on urethroscopy. 99 technetium DMSA, it is initially used to provide differential renal function with technetium MAG3 renography and ultrasound follow-up. Then let us talk about anterior urethral abnormalities. It is 10 times less common than posterior urethral valve. Anterior valves may be located anywhere along the anterior urethra, often associated with a urethral diverticulum. Severe valves are often diagnosed in the newborn period. Micturating cystourethrogram show typical ballooning of the urethra with the deviation of the penis may occur during micturation. A syringocele is a dilated Cowper's gland or duct that may cause urethral obstruction in the neonate. Sometimes non-specific symptoms of dribbling or hematuria may occur later in childhood. Spontaneous rupture or transurethral incision is curative but may lead to a urethral stricture. Urethral stricture, where it is located, 75% of male congenital urethral stricture occurs in the bulbous part of the urethra. It is the region where embryological proximal urethra merges with the urogenital membrane and at the urethral meatus in case of girls. And in acquired cases, urethral strictures may be located, such as in traumatic stridal injuries lead to bulbar strictures, pelvic trauma and urethral rupture or catheter-induced injuries tend to cause stricture either at the bladder neck or membranous part. So how they present, how the urethral stricture present. Early presentation as a neonate may demonstrate significant upper tract dilatation secondary to urethral obstruction. Post-pubertal boys present with irritation, urinary dribbling, hematuria, urinary tract infection, as well as prostatitis or epididymitis. Rectourethral fistula, usually associated with an imperforate anus and is best demonstrated by a high-pressure lupogram via a distal colostomy, which should demonstrate passage of contrast from the bowel to the posterior urethra, or by high-pressure ureterogram or during voiding on a micturating cystourethrogram. Duplication of the urethra. A rare congenital abnormality usually discovered in the childhood with one of the urethras ending as a hypospadias. It may be complete and the child present with a double urinary stream, urinary tract infection, sometimes outflow tract obstruction and incontinence. Thank you a lot for listening.